Dr. Narayanappa sir, namaskara. Dr. Singaroilu sir, good evening. Ravi Shankar, good evening.
ಹಲೋ ನಡಿ ಹಿಂದೆ ಕುತ್ಕೊಟ್ಟು ಕಳ್ಸಿ. ಹಾ ಕೊಟ್ಟೆ. ಇದು ಎಷ್ಟು ಕಂಪ್ಲೀಟ್ ಆಯ್ತು. ಎಷ್ಟು ಇಡ್ಸಿತ್ತು? 2.5 ಏನೋ ಅವ್ರದ್ದು. 1 ಲೀಟ್ರ ಕಡ್ಲೆಕಾಯಿ ಎಣ್ಣೆ. ನಾನು ಬರ್ತೀನಿ ಇರು. ಬಾ, ಹೋಗೋಣ ಬಾ. ನಾನು ಬರ್ತೀನಿ. ಅದೇ ಈ ಕಡೆ ತೆಗಿಬೋದೇನೋ? ಅದು ಈ ಕಡೆ ತೆಗಿಬೋದಾ? ವೆಹಿಕಲ್ಸ್ ಬಾ ತೆಗಿ.
Singaroilu sir, good evening. Namaskar sir.
Good evening, ma'am. Good
Good
evening.
evening sir. Good evening sir. Dr. Sheetal sir, namaskar. Sir, आप म्यूट हुए हैं. You're muted sir.
Yeah, good evening, madam.
Good evening, good evening. Sir, मैंने आपसे बात हुई थी. I had spoken to you about 1 month
Sunita,
ago.
good evening.
Sir, namaskara sir. How are you sir?
Namaste. Better, improving.
So good to see you sir. So good to see you back. Wonderful. Thank you sir. Dr. Sheetala, I had spoken to you.
Yes, ma'am.
Yeah. Hope you remember. Yes. So nice to see you, sir, online.
Yes, ma'am. Yes,
Thank
madam.
you. Dr. Jose, sir, good evening.
I'm traveling and just within 5 minutes I join.
Sure,
I'm
sure.
traveling just 5 minutes.
Okay, sure, sir.
Sure.
Sir.
Good evening, Joe, sir. Good evening.
Good evening, sir. Good evening. Good evening, Shekhar, sir. Good evening. Good evening.
Okay.
5 minutes I will join. No problem.
Sure.
I will become.
Supraja, good evening. Supraja, do you want to check the slides?
Hi, good evening.
Hi, Supraja. Do you want? I think it's better if you please check them.
Yeah.
I'll share the YouTube link also. You can share it on all your groups, Supraja.
Is this visible?
Not yet. It's just said started sharing. Not yes. Yeah, there are some black bars around
Oh,
on the side, especially.
does this make it better?
No, not really.
This is in full set.
Yeah, but there are 1 minute. I'll just take a screenshot and share it with you. Just see what you can do about it.
Oh dear. Okay.
I've just sent it to you, Supraja. Please check. That's how it is showing up on the sides.
Is this visible?
Not yet. It's just said started sharing. Not yes. Yeah, there are some black bars around on the side, especially.
Does this make it better?
No, not really.
Is this in full set?
Yeah, but there are 1 minute. I'll just take a screenshot and share it with you. Just see what you can do about it.
Okay, dear.
Dr. Janni, good evening.
Hi, good evening.
Good evening. I requested Supraja to just check the slide
Yeah,
deck.
Let me just. Shall I try again, Sumita? I'm not
Yeah,
sure.
please.
Does that Sumita? Is that visible?
yeah, now visible. Yeah.
Visible, but again, the black bar on the top, well,
That
it's...
is the Zoom kind of that bar with audio, video, and all of that. That's what's coming.
No, below that. Okay, I think you have to move it a little bit now. It's better, but
Now
there's
it's
something.
better. Now it's better.
Yeah, can you just move the next slide? Let's see.
What? Why is it not moving? God.
Click inside the slide.
Yeah. So, okay, it's moving, but there's a black bar on the side.
Yeah, not on the side, on the top.
Top and on the side, no? There,
That
I'm seeing
top
it.
thing, I have taken it out. That is the panel of the Zoom. I don't know why it's showing.
Side, there is one more black. Move the next slide. Is it seen in all the slides?
Yeah, it's seen
Yeah,
on all the slides.
everywhere.
Yeah. I've just sent it to you again, Supraja. Just see.
Sure, is it the way we are sharing? Just 1 second.
Some software mismatch it can be.
Okay, just can we try now?
Yeah, it's there.
Still coming?
Yes.
I mean, that bar is coming, ma'am. It's not proper.
Yes, it is still there.
Oh, God.
That's fine. I think it's not hiding the content.
Come on.
Just move on. Don't worry.
No. Content only.
You have an Apple or which
No,
laptop?
ma'am, a normal Windows. I'm just thinking application Windows.
You're putting it on the desktop, opening it and keeping it, no?
Yeah. Now?
Now also it's there.
Oh God. Okay.
Very much there. I think you just ignore it.
Do you want to
Remove the
send it to
top
me?
black alone, yeah. Or send it to Sumita, let her share.
I'll just ask one.
What happened,
Hi,
Supraja?
Supraja.
Can I help
Hi,
you?
Ravi.
Yes,
Hi,
sir.
sir. Good evening, sir.
Hello, sir.
Hi,
Hello, Ravi
Namaskara.
Shankar, sir.
Good evening. Good
Namaskara,
evening to all.
Lord
Good evening
Ji.
to all.
Madam, namaste.
Namaste, namaste.
Namaste.
Naranappa, all well, good, nice to see you.
Good evening.
Kishore,
Ravi Shankar sir, good
ಚೆನ್ನಾಗಿದ್ಯಾ?
evening.
Sir, yes, sir.
Good evening, Dr. Kishore
ಚೆನ್ನಾಗಿದೆ
sir, Dr. Nagesh
Good evening,
Singarvel
ji.
sir,
ma'am.
good evening.
Namaskaram,
Singarvel sir.
Singarvelu, sir.
Sir, Kishore sir, Narayanappa sir, good
Welcome.
evening, good evening. Oh,
Good evening, sir.
Good evening, sir. Good evening.
Nagesh, good
Good
evening.
evening.
You're traveling, is it?
Naranaji, good evening. Sumita Naik,
Good evening.
good
Good evening, good
Ravi
evening, good evening, sir.
Ravi
good
Shankara,
evening.
reach.
Nagesh sir, good evening, sir.
Good evening.
Nandi sir, good evening, Nandi sir.
Oh, namaste, sir. Namaste, sir.
Yeah.
Good evening, all, sir.
Nandesh, good evening.
Good evening,
Good
Dr.
evening, sir.
Nandesh.
Good evening, sir.
Nandesh, good evening.
Good evening, sir. Narayanappa, sir. Namaste, Sinjo. Namaste.
Good evening, Dr. Nandesh sir.
Madam Ji, Sumita, Madam Ji, namaste.
Namaste, namaste.
Sumita, is this better?
It's gone.
Yeah, it's
Oh,
not there
fine,
now.
fine. It's fine. It's fine.
Okay, great.
What did you do?
I prayed.
This was one of the emergencies.
It
Real
actually
emergency.
worked.
One thing. More.
Ravi Shankar, start ಮಾಡೋಣ.
So you're a Basaraja?
Madam.
ಕಾಲ್ ಮಾಡ್ತೀನಿ.
Start ಮಾಡೋಣ ಮೇಡಮ್.
ಒಂದ್ ನಿಮಿಷ
Yeah,
ಬಸವರಾಜನ್ನ ಕಾಲ್ ಮಾಡಿ.
Kushal.
ಸರ್.
ಮಾಡಿ. ನಾನು ಕರಿತೀನಿ. ಕುಶಲ್ ನೀನ್ ಶುರು ಮಾಡು.
ಸರ್ ಶುರು ಮಾಡ್ಲಕ್ಕ?
ಮಾಡಕ್ ಹೇಳಿದ್ದಾರೆ, ಸ್ಟಾರ್ಟ್ ಮಾಡಿ.
Good evening, Nandesh ji. Good evening, Nandesh ji.
Sir, namaste. Namaste, sir.
Namaste. Some connectivity issues, so that's why I am coming in video.
Okay,
sure,
okay. Okay, sir.
Good evening, all.
ಮಾಡಿ.
Good evening, all. I am Dr. Kushal, Secretary of IAP Karnataka. I am pleased to welcome all the guests, seniors, teachers, members of the OB, EB, and the seniors who have joined.
Jose, we heard it. Yeah,
Sir?
thank you. No, Jose was telling that is connectivity. Yeah.
Sir, it's my pleasure to launch the first webinar of the team Karnataka IAP 2026 under the President Dr. Ravi Shankar, Convener Dr. Sumita Naik, and Coordinator Dr. Nandish, with the blessings of our seniors and mentors. And this launch is mainly for an academic connect with the practicing pediatricians with the different subspecialties. And we focus on the case-based discussions and learning with the expert inputs from the doyens of the field. And I invite President Dr. Ravi Shankara for the opening remarks.
Thank you, Kushal. I welcome all the seniors who are here to bless the team IAP Karnataka 2026. And this is the this is the thing that is something called as K Samanvay, means K means knowledge. So Samanvay means we'll learn together. So in Kannada, Kudi Kaliyona, so that is the meaning here. So we learn together and express our whatever the things are there. We'll discuss and do the things. That is the meaning of Samanvay. So where it is nobody is great or nobody think all are equal. We want to learn each other and help the society and the children. That is the meaning of this K Samanvay. So we will try to do once in 15 days, covering almost all the present subjects. So this is the one with the emergency medicine. So where we know the emergency medicine taking place in forefront and it almost helping the kids in managing, in helping the doctors to manage the kids during the emergency times. So that is one of the thing here. And Sumita has taken this job in spite of her busy schedule. I really congratulate her and thankful to her for taking this job. And also I welcome my dear friend, almost like my elder brother, Dr. Singaravelu sir, who is the president-elect, and also Joe Joseph, my great friend. He is also there, the vice president of the South Zone, and others, Dr. Janini ma'am, and my Naranappa sir, my teacher during my PG days, because I have learned so many things and able to practice so confidently because of Naranappa sir, and Kishore Bandar, my DNB teacher. All our people are there who are I'm really blessed to have all of you people here for this occasion. So with these brief things, I request Dr. Kushal to take over the proceedings.
Thank you, Dr. Ravishankar. And now I request our chief guest for the evening's lunch, Dr. President-elect, Dr. Sringaravelu sir, for his address.
Thank you, Dr. Kushal, Secretary sir. The most dynamic, very active academician come President of Bangalore branch, none other than my good friend, Dr. Ravishankar Marpalli, and our treasurer Abhishek, and my seniors, my good friend, the Narayan sir, Kishore sir, Nandish sir, and today's convener for the entire this academic program, and how Sumita ma'am was as a president, she has done the last year, and prior to that we know her academic skill, and she has brought the correct person even on the first day. None other than Janani ma'am is there, who will be able to give expert opinion for the practitioners. That is what more important. And Supraja and Swati all can do extremely well because what is needed for a practitioner in an emergency setup in their OPD practice is a very good topic. And all the seniors are here. I don't want to take everybody's name without wasting my time. I always consider Bangalore as always Bangalore people used to tell it is an extension of my second home. The way I was given, I should take this opportunity to thank each and every one of you for giving me this opportunity to lead our association for the coming year 2027. It has happened, it is only because of your support. And today, our guest of honor, my good friend, our South Zone Vice President, Joe sir, also here, and Basara sir, my president, who he has also joined, under whom I, as a vice president, I was able to do a lot of program. So I should be always thankful. And whatever program were done at the period of vice president and Bangalore with the Nandishar and others, I was there with you all. And I'm sure that with all your guidance, definitely we will try to do the best during our tenure as a president, because you are all part of our team. So with this, I thank each every one of you, and especially our president, Dr. Ravishankar Marpalli, and convener, Sumita ma'am, our Priya Shwali ma'am also have joined, and secretary, treasurer, and all the seniors, and my president, Dr. Basavara sir, Nandishar, and all that. So with this, once again, I'm sure that this program, I'm very proud to be being the first webinar to inaugurate it. Surely, Bangalore is known for its academic. I know all over India people will be joining through YouTube. and definitely it will be a very successful program in future also. And wish you all and happy learning to all the viewers. Thank you for giving me this opportunity.
Thank you very much, sir. Thank you very much for your enlightening words, sir. Now I call upon our guest of honor, Vice President South Zone, Dr. Joe, sir, to tell few words.
So, thank you, Kushalji. And in view of the connectivity, I am stopping a video. Respected our IAP Karnataka State President, Dr. Ravi Shankaraja, and Secretary, Dr. Kushalji, and again the immediate past President of IAP Karnataka, Dr. Smita Naik, Madam, our National Vice President, past National President, Dr. Basaraji, Dr. Nandish, our President-elect, our leader of IAP in the National, Dr. Singarivelu, sir, and all the dignitaries on the dais. Today, the program under leadership of Dr. Janini Madam sir, and going to deliver the important topic on pre-up and managing emergencies. I think this is a new concept of manage the program narrated by Dr. Ravi Shankar ji and team. For coming 1 year, they are planning to conduct a regular once in 2 weeks. They are planning to conduct a topic beneficial for the practicing pediatricians concerned. I think it is a need of the hour. I think the IAP Karnataka is always in good in academics, and with under leadership of Dr. Basaraji, the national president in 2024, shown that there is how the academics run to that year. Show that support from IAP Karnataka. He done a wonderful activity last year under leadership of Dr. Singarival as Vice President. This year, under leadership of Dr. Ravi Shankar ji, going to roll out the program pre-up emergency management. Actually, it is a new concept. The perceivance of rapid and rapid assessment of emergency response and escalate and parent and update regarding the program emergency situation. I think this pre-up response emergency management is preparedness is very important, because our common that is will be useful for the general practitioners concerned how to be there well aware of how to tackle the emergency in a proper ways. Under the our first program under leadership of Dr. Janani Madam is here. I think this is very useful for our practicing pediatricians concerned. I think IAP Karnataka is doing a wonderful activities. As a Vice President of IAP South Zone, I am honored to attend the inaugural function of this program along with our President-elect Shingariveli sir and all the dignitaries from the Karnataka, the expert in the field. I wish you all the best program. Always along with IAP Karnataka, as Shingarivelu mentioned, sir mentioned. Karnataka, Tamil Nadu, and Kerala as a unity. There had to be working both in academics and or organizational activities, and we will work together for the benefit of Central IAP is concerned. I wish with this phrase, I wish you all the best for program. Jai Hind, Jai IAP.
Thank you very much, sir. Now I request our own Dr. Basavaraja, National President 2024, to comment.
Thank you very much, Kushal, and our President-elect of Indian Academy of Pediatrics, Professor Singaravelu sir, and de facto President of our South Zone. For all practical purpose, our President is Professor Jose, who has been very instrumental in galvanizing all the branches to do the excellent activity. We are very happy today. The Karnataka is starting an online academic program, especially which is an emergencies led by none other than Dr. Janani Madam, Dr. Supraja, Dr. Swati Rao, and Dr. Ravi Shankar Marapalli, our Karnataka President and Secretary, Dr. Kushal, along with the great support from our academic coordinator.
I think sir's connectivity, yeah.
There is some problem with the connectivity with sir, I think.
Kushal, you can go ahead with others.
Out academic activity with
sir,
the
yes,
great coordination from Dr. Sumita Naik and Dr. Nandish. So I'm sure this is the series which is going to make a big difference in the academic activities. Best wishes for the today's program. Thank you very much.
Thank you very much, sir. I thank all the attendees who have attended this launch. And now it's time to start the academic session. Now I call upon Dr. Sumita Nayak, our coordinator for this Samanvay and Vice President of Karnataka Bangalore Zone and past President of Bangalore 2025. Over to you, madam.
Thank you so much, Dr. Kushal. Good evening and a very warm welcome to all the dignitaries, Dr. Singaravelu sir, Dr. Jose sir, Dr. Basraj sir, and Dr. Ravi Shankar. Thank you for the opportunity given. Without much delay, we will delve into today's program. So as has been mentioned by Dr. Ravi Shankar and Dr. Kushal, we are going to having these sessions every 2 weeks. And today we have a very, very important topic that is going to be covered with our young faculty. And we are honored to have none other than Dr. Janani, who is going to be the expert for this evening. So it is an honor for me to introduce a good friend, Dr. Janani Shankar, who is currently the medical director at the Kanchi Kamkoti Child's Trust Hospital at Chennai. She has been the president of Tamil Nadu for the year Unbight and TN president for 2025. And she has her areas of interest cover emergency medicine, hematology, rheumatology, and infectious diseases. So Dr. Janani, thank you so much for accepting to be the expert faculty of this evening. And before I introduce our young faculty, Dr. Supraja and Dr. Swati Rao, I request Dr. Janani to give a few words of I think
thank you.
Excellent gyan from your side. Yes, doctor.
Thanks, Sumita, for inviting me as an expert for your first program of online program of IAP Karnataka. Thank you, Dr. Ravi Shankara, Dr. Kushal, and others, other office bearers. I think it's a wonderful thought that we're trying to educate the practitioners with a series of something that will definitely they'll benefit from such type of programs. I'm sure we'll try to, with the help of Swati and Supraja, the young emergency and intensivists, we will definitely try to make this next half an hour to 45 minutes. We try to give crisp messages with, of course, clear and crisp messages. I'm sure we will do our best. Thank you, Sumita, and thank you, the IAP Karnataka team.
Thank you so much, Dr. Janani. Before I introduce our two young faculty, the program today is all case-based discussions. There we are going to have 4 cases, and at the end of each case, Dr. Janani is going to give her expert inputs and comments. So we will definitely have a session on the audience questions and interactions. Probably we will take it at the end of the session. So we will run through the 4 cases. And for this, we have none other than Dr. Supraja Chandrasekhar, who is the Director of Pediatric Services and a pediatric intensivist, as well as a co-creator of the Hospitals. Dr. Supraja is well known across for her very, very educative social media content, which she often uploads and shares. And so Dr. Supraja actually is the brainchild. This program is her brainchild. And to assist her, alongside her, we also have another excellent faculty, Dr. Swati Rao, a pediatric intensivist, who was the in charge of pediatric ICU at a tertiary teaching hospital. And she is currently working in the KMC group of hospitals as the lead intensivist. So without any delay, I hand it over to you, Dr. Supraja and Dr. Swati, for the deliberations over the next half an hour to 45 minutes. It's over to you.
Thank you so much for this wonderful opportunity. I'm just trying to share my screen. Is that visible?
Yeah. Again, the black has come.
Oh, God.
You didn't pray this time. It's okay. I think we'll manage. Push the top bar alone up. Yeah.
Yeah, go ahead.
Okay. Ma'am, over to you. You could start off.
Yeah. Can I have the next slide? So this topic was chosen because practitioners, as practitioners, we always think, I mean, by practitioners, I mean the consultants who sit in the outpatient department of a teaching hospital or of a corporate hospital. So what we think is we're just going to see patients who are very well, who just walk in, come to us with either an URI or a constipation or a well baby who comes for immunization. I think we should understand that we all should be prepared for an unexpected emergency in the busy outpatient department. Next slide. So this often doesn't really strike many of the practitioners because there are no laid formal guidelines. If you look at a nursing home or a clinic where the doctor practices, there's just a receptionist and him and maybe a nurse to help. Time constraints because they're busy practitioners, they try to practice throughout the day without a break. There's some lack of proper equipments like proper oxygen cylinder or a bag valve mask, or drugs like epinephrine sometimes are outdated or not being replaced. Transport issues, they don't have proper transport from their place to the tertiary care center if they want to transport. And of course, medical legal implications, they are not familiar with what happens when a road traffic accident child comes or an abused child comes. These are all the challenges that we have in the Indian setting. So the types of pediatric emergencies, so one should be familiar with the emergency medical services that is available. For example, your ambulance number. In Tamil Nadu, of course, it's 108 is the government ambulance. I think in Karnataka also it should be the same. You should have also a list of tertiary care hospitals which have ICU facility. You have to have the contact numbers of the intensivists and the contact numbers of ambulances, and also the protocols and the guidelines should be available readily in your desktop or your pasted in your walls of the clinic. So if you have all these things and you also have minimal training of your staff in basic life support and simple first aids, I think even a person who's giving immunization can have an unexpected emergency. And I think you should be prepared and also be ready with all the equipments and the drugs. Next, please. Yeah, this I already mentioned. I think with this small introduction, we thought we'll talk about 4 cases where you had an unexpected emergency in the busy outpatient department when you're seeing regular patients. Maybe you're a busy practitioner seeing about 50 to 60 within a span of 3 to 4 hours. You have one emergency, your entire 30 or 40 who are waiting, they have to wait for hours together. So we'll just see how best you can manage these emergencies. Over to Swati and Supraja to take over the cases.
Yes.
Just a minute, Swati, I'm sorry to interrupt. Dr.
Yeah.
Nandish, the coordinator of this session, Dr. Nandish requesting a few words from you. Dr. Nandish? Dr. Nandish? Okay. Dr. Ravishankar, can we continue the program? You have to unmute.
Yeah, we can go ahead. I think he
Okay.
just become busy.
Okay.
So
Yeah.
Naranappa sir is there. If you want 2 words from Naranappa sir, Kishore Baindur sir.
Sir?
No, please don't interrupt. Continue. You're already in
I'm
the
really
Then we'll go.
so
Then we'll go.
please,
Yeah.
please.
Okay, then we'll go ahead. Go ahead. Go ahead.
pleased. Yeah.
Supraja, go ahead.
Okay.
I heartily congratulate the team, Karnataka IAP, led by Dr. Ravi Shankar, Kushal, and coordinated with Sumita Nayak, Nandish, and for having started a wonderful program, educating on practical tips. It is a little different. The idea installed is quite appreciable because the straightforward bullet type of case scenario and the action diagnosis, what you do, such approach will benefit the practitioner as a whole. So I wish the
Yeah, sure,
program
sure. Don't
all the
worry.
best,
We'll take it.
and I appreciate again. So
Thank you, sir.
Swati Rao and Kishore, my good friend who has taken the respiratory sector in Karnataka. So over to you.
Samita, we
Yes.
can go ahead now.
Yes, thank
Yeah,
you, thank
we
you,
can.
thank you, sir.
Yeah.
Swati and Supraja, back to you.
All right. First of all, many thanks for giving this opportunity to me, and I mean I feel really great to be in front of my mentors, seniors. My teacher, Dr. Kishore, is there, and Dr. Sumita Nayak, Dr. Ravi Shankar. All of you are like mentors to me. So quickly moving ahead. What are the essential equipments we should have in our OPD? We are talking only about OPD over here. So we definitely, there will be space constraints. There'll be constraints to, check whether the equipments are working. So we are talking about the minimum equipments which we have to keep in our OPD, not the entire crash trolley that we have in our ICUs or emergencies. So basic minimum coming to the airway. Main thing, we'll have problems in airway management, so especially breathing. So in our poll also, we found out that the respiratory emergencies are the most common emergencies we deal in our day-to-day practice. So minimum oxygen delivery systems, low flow devices, high flow devices, nebulization systems, and very important, oxygen source. So it may be an oxygen cylinder which is portable, or it might be a bigger oxygen storage system, which is a must if we are dealing with a lot of respiratory cases. And having a multi-para monitor also becomes very important. If a child is having dehydration, we are not able to check the BP, taking manual BP, we don't have manpower. So, having the small, instead of having a small pulse oximeter, having a whole multi-para monitor, if we invest on that, our lives becomes very easy. And definitely for vascular access, we need to have IV lines and maybe a intraosseous. Coming to medications, definitely we all give vaccines in our OPDs. So we will expect some anaphylaxis happening. So epinephrine injection is a must-have in your OPD, and including hydrocortisone and phenylephrine, and definitely we see a lot of febrile seizures. Even a child's waiting for you in the OPD can suddenly have a seizure. So having a midazolam nasal spray and IV midazolam becomes very important. And if a child wheezer comes, or a child having sepsis comes, maybe a simple antibiotic like ceftriaxone becomes important. And of course, your anti-seizure medication, as I have already mentioned, and nebulizing medications. And it's better, we never know when we'll have to transfer these children, and we better have a document where we can jot down what are the resuscitation measures taken for this child, and then where we are referring, how we are referring, especially for medical legal purposes. This becomes very important.
Thank you, Swati. And thank you for this opportunity. Now, it's not enough to just purchase these equipment and keep it. It's very important that we train whoever staff we have. Most often, we may just have one more staff with us. 30% of the pediatricians have told us in the survey that they have only 2 staff. So at that point, answering the calls, documenting how to actually transfer this patient, how to triage this patient becomes very important. As Janani ma'am said, we need to know the 108, how do we call them and what information they need, as well as the closest private hospital, the basic cost. A written document kept near the phone makes a big difference. So whoever is your receptionist can do that. A simple triage, the traffic signal method. Most of our OPD cases are non-urgent, but sometimes when it's a high-grade fever or a child is moaning, vomiting excessively, severe rashes, etc., comes in the yellow zone, which requires urgent care. And the red zone is something which affects the A, B, or C. So if your airway is compromised, the child is struggling to breathe, or apneic, or seizing, etc., that is a red zone. And the receptionist or even the non-clinical staff has to alert the doctor immediately or alert the ambulance. Having a protocol or a guide helps a lot, because sometimes we may forget things, forget doses. So a simple thing like we have a prep-up manual can be kept at the bedside. Now, do you think that just purchasing equipment, hiring staff is important? The most important thing is not all of this. It is to actually mock run it. So one day when the OPD is free, it's important that we run a quick mock drill or a mock code. It could be a simple case, just a febrile seizure that has suddenly happened. What do we do? Who is calling who is calling for the ambulance? How do we stabilize? Who answers? There are other patients who are, very, very impatient waiting in your OPD. So mock drills are an effective solution. So the 5 P's for any emergency preparedness would be: first, to prepare is, where is your OPD? Is it close to a hospital? Do a self-assessment. Second one is to protocolize and train your staff. Third is to make the most important purchases. Fourth one is to actually practice and do a mock drill. And the fifth one is, once you practice, you find the difficulties, you find the deficiencies, and you correct it. So don't forget these 5 P's. So we all know the common emergencies are anaphylaxis, respiratory emergencies, seizures, and of course, trauma, minor trauma, as well as foreign bodies. Now, we'll start with a case-based scenario. Let me begin with this 9-month-old baby who was brought with high-grade fever, was waiting in our OPD. It was a typical busy Saturday evening, and the mother had wrapped up the baby completely because the baby had a cold. Suddenly, she screams that the baby is abnormally looking to one side and is not responding. The receptionist immediately rushes the baby into your chamber. So let me ask Swati, what is her assessment and how would she handle this?
Of course, this is one of the most common, scenarios, a child waiting in the OPD seizing. So we have to manage the seizure because seizure looks very dramatic. Everybody is panicking over here. So the first and the foremost thing is, you should calm the parents, tell them that this child has a seizure, and send one person outside to tell other, parents waiting outside not to panic, not to create any chaos there, and then get the patient's details. And first thing is here to abort the seizure. Why? Because once you lose that window where you cannot abort the seizure, then it can become refractory. So the first thing to do is, if you can establish an IV line, that is the best position, so that you can keep the airway patent. If possible, suction the patient. Otherwise, if you don't have that facility, just put the patient in the left lateral position and keep midazolam nasal spray very much handy. And giving this 0.2 mg per kg, especially for a child, like say 10 kg child, 2 sprays on each nostrils is life-saving. If you cannot establish an IV access, you can just give it IM 0.1 mg per kg. Check sugars, and if the child is going into status, definitely you have to load on injection levetiracetam 30 mg per kg, dilute it in 100 ml NS and give it over 10 minutes. Because here, what are the challenges we face over here is mainly, you may not have the drugs, or you may not have the airway stabilizing equipments. So why we do this very fast is the problem. Now we have redefined status epilepticus in a way that any child seizing in your OPD, don't wait for it to cross 10 minutes, 20 minutes, 30 minutes to say that it is status. Any child coming to your healthcare facility convulsing has to be considered as status, because if you allow this patient to seize for beyond 30 minutes, it becomes refractory. So the ILAE has redefined it, and they have considered 2 points of time, that is T1 and T2, to define status. So no longer wait for more than 30 minutes to call it as status. And then why? Because approximately 30% patients presenting state epilepticus is the first. So we don't know whether it is a seizure disorder or just a febrile seizure, but we have to be cautious. And whenever you are referring, so refer to a hospital which has a PICU setup, because this child will definitely require a MRI or a CT to find out what is the problem this child is having, and immediate intubation and ventilation might be required if the child goes into refractory status and has airway abnormalities. So quickly we'll go to the next question. Next case. So we have
I think we'll just summarize that case.
Okay, ma'am.
Swati. So I think the case was very well discussed by Swati. I think this is the most common emergency that can happen in the outpatient department, because febrile seizure is something very, very common. And when the first seizure, when the parents see, it is really very panicky for them. But as she said, first thing is to convince them and say that it's nothing, we'll take care. And midazolam nasal spray, bag valve mask has to be there in the outpatient department, because by the time you shift the child down, the child can also have a respiratory arrest. So a bag valve mask ventilation is mandatory. You have to be trained. And of course, midazolam nasal spray or IM midazolam can be given, and the child can be shifted down to the emergency or wherever, to the other hospital. But if you're going to shift to the other hospital, kindly check the sugar, get an IV line secured, load with levetiracetam or whatever drug you're comfortable with. Because again, the drugs, the order is anything that you're comfortable with, you can give. It's not that you have to give first phenytoin, then phenobarbital. Those things are gone. Levetiracetam, we are very comfortable because it is really good even in a newborn baby. Doesn't have much side effects. That's why she has chosen levetiracetam. But if you're an old timer and you're comfortable with phosphonatoin, there's nothing wrong in giving even phosphonatoin. So start the drug and try to transport the child intact. Okay, move on to the next case.
Thank you, ma'am, for that summary. So we'll move on to the next case. So this was a very common scenario. There was an adolescent who came for the vaccination. You gave her Tdap vaccine, and then child had no issues. And then the parents immediately went, and then they were just doing the billing, and she suddenly collapsed and hit her head on the edge of the reception table and had a cut. So it became very dramatic, the scene. Everybody started panicking. Of course, the receptionist rushed the child inside your chamber. Dr. Supraja, what is your assessment? And in this panicky situation, what will you do?
Yeah, I think the first thing is we have to look at the probability. This child was actually well, walked down up to the billing area and then possibly collapse. So I would actually consider vasovagal syncope as my first differential. I would briefly explain to the parents as I stabilize the child on the bed, probably just keep the child lying flat and want to lift both the lower limbs above. In the meantime, I will tell the receptionist to kind of inform the rest of the OPD as well as to get the vitals monitor. It's very important that I put one hand on the pulse to check the pulse rate of the child. Most often, I would expect the pulse rate at that point to have become lower during a vasovagal attack. But if the pulse rate is high, it's tachycardic, the PP is low, and the pulse is thready, I am really thinking of anaphylaxis there. And in that situation, I would definitely ask my receptionist to immediately call the ambulance because this child can sink at any point. And if I'm finding that situation, I would get an IV access and start a saline bolus immediately. And at the same time, explain to the parents that it looks like a severe allergic reaction. Now, on the other hand, if my diastolic is very low, usually if the diastolic blood pressure is less than half the systolic, I know that this is a low diastolic, pounding pulses, typical distributive shock that I get in anaphylaxis. And at that point, I would rush to take adrenaline, and it would be undiluted adrenaline 0.01 mg per kg, which is the same as 0.1 ml per kg, and I would give that IM stat. I would not wait for any IV access. But if the child's blood pressure is okay, there is no rashes, there's no cold and clammy skin, child actually looks fine, was very pale when it came in, but now looks okay. It is just that little cut on the head because of hitting on the reception table. Then I probably will just ask the child to lie down for a few minutes, initially with the legs up. Here I'm suspecting vasovagal. Document this, that the child had a possible vasovagal attack. Recheck the vitals again. Talk to the parents, and when the child is ready to sit up, ask the child to wait for a few minutes outside. Again, reassess the child and then carry on. So how I would differentiate anaphylaxis versus syncope is first, we'll look at the onset. Anaphylaxis can occur immediately, but also can be delayed up to 4 hours. That is when the child actually goes home. Secondly, usually skin manifestations, be it urticaria, angioedema, pruritus, or generalized redness can happen. On the other hand, in a vasovagal syncope, it occurs almost immediately within a few minutes, and the child looks very pale, cold and clammy skin, and child is a bit shocked. Respiratory wise, you can have in anaphylaxis starting from stridor, hoarseness, cough, sneezing, rhinorrhea, etc., whereas nothing is affected during a vasovagal syncope. Cardiac-wise, tachycardia is classic in anaphylaxis because of the shock, whereas the bradycardia, which is reflexive, is typical of a vasovagal syncope. Neurologically, the severe anxiety and distress or even loss of consciousness in syncope can happen as part of anaphylaxis, whereas the lightheadedness, dizziness, and then regaining of consciousness happens in a vasovagal. So there is plenty of evidence to say that after routine vaccination, venipuncture, simple blood tests, etc., vasovagal syncope can happen. And it is more common with blood tests than with vaccination. And they have documented serious injuries because of the child falling off. So it's a good idea after vaccination to keep them sitting in the OPD for a few minutes, at least till the billing, etc., happens. And also to talk, especially to the adolescents, that they may have a fainting episode. So we'll just watch out for this.
Yeah, I think that was, yeah, I think that case is over, no? Yeah. So I think, Sukraja, really, the spectrum is from a vasovagal syncope, as simple as a vasovagal, to a serious anaphylactic shock requiring inotropes. So I think she very nicely delineated the differences between vasovagal syncope as well as anaphylactic shock. Again, it's preparedness, counseling the parents, acting calmly, and getting things properly done without even not only the parents, the treating physicians and the others around also should not panic. And again, the crowd waiting outside has to be explain that there is an emergency inside, or you can shift this child to a side room if you have a procedure room or something. Shift there and ask your assistant or some junior staff to take care, and you can proceed with the other outpatient. That is another emergency. They'll start shouting, they'll start taking videos and other things. So the waiting parents, that is also an emergency. Causing chaos is also an emergency. So we'll have to tackle two different emergencies at this point of time. Okay, move on.
Thank you so much, ma'am. It's so true that waiting parents creating chaos is definitely an emergency.
Yeah, that's more difficult to manage.
Yes, ma'am. Let's move on to the next case. Here we have a 2-year-old child with a history of febrile seizures. Mother brought the child with the onset of fever as she is extremely anxious. Now, child had some cold, fussiness, was otherwise well. A dose of clobazam was given at home. Now, despite the paracetamol, the temperature was 103. Mother is extremely anxious and demands immediate reduction of temperature. So you, in that pressure of the moment, have given diclofenac or a Zonac suppository with symptomatic treatment. 20 minutes later, the child brought with cold peripheries, drowsy, and difficulty, noisy breathing. So Swati, what do you think you would do here?
So I think this is a real problem, because we all know that how parents are very paranoid about bringing down the temperature. How much ever you counsel them, they are worried 102, 103, 104. So how much ever you say, but with the pressure, and most of the children in that, when they are very febrile, they're not able to take the paracetamol syrup. You end up giving diclofenac. So, and then you cause this problem. So here the child is really cold and having rashes, and definitely I think this is no vasovagal. This is definitely anaphylaxis, and all of us should be prepared for this kind of situation. And counseling becomes very important, because now they know that you have given diclofenac. You better say that it is a known drug which can cause anaphylaxis, and ask them not to panic, and you tell them that you have the situation under control. So now how to control the situation? First, check the vitals, because in anaphylaxis, it may range from just a rash or till the child can be hypotensive as well. So checking the vitals and how serious is the anaphylactic reaction, to assess that becomes very important. If there are secretions, you have to start oxygen, suction it out, and check whether there is stridor, wheeze, shock, rashes. So what is there, and we have to give the management. So first and the foremost, we all know that adrenaline becomes life-saving over here. Don't worry about diluting. Don't worry about establishing an IV line, which is we are going to waste time over there. Just take 0.5 mg per kg of the adrenaline, load it in your 1 cc syringe or your tuberculosis syringe and give it IM. So don't give it subcutaneous again, give it IM. And if the patient is conscious, put the child in supine position, and maybe if the child is hypotensive, lift the leg up. If the child is unconscious, better secure the airway or put the child in left lateral position. And if you feel the child is very sick, send someone to arrange for an ambulance, because definitely this child is going to require observation and you may not have the time or the manpower to observe this child further. And if the child is hypotensive, definitely you have to secure an IV line and start a saline bolus. Keep the steroid ready and give 1 shot of steroid hydrocortisone, and never leave the child unattended until you get help, and then you safely shift this child and document this. So now you know that diclofenac has caused anaphylaxis. So you document in bold letters, maybe in red, in the child's file that this child is allergic to diclofenac. So about anaphylaxis, we all face it very commonly with post-vaccination. And general incidence also is pretty high, 1 in 1,000. So post, some food or insect bite, atopic children have more risk of developing, and post drugs, antimicrobial, beta-lactams, and NSAIDs, like in this case. So these are the exhaustive list of drugs which can cause anaphylaxis. And then what do we do? How do we approach this child? So again, you have to see whether in this child it's just an upper airway obstruction, lower airway obstruction, or the child has progressed into shock. If it's just adrenaline is common. In all the 3 scenarios, you have to give adrenaline IM 0.01 mg per kg of 1 in 1,000, that is without dilution, and repeat every 5 minutes if needed. So if it's just an upper airway obstruction, we can start off with high flow oxygen and establish an IV access and give corticosteroids. Probably it is a upper airway, edema, tongue edema or a laryngeal edema. If you can hear wheeze and the child is having respiratory distress, then definitely you have to give salbutamol nebulization and steroids. But if the child has progressed into shock, establish an IV line, start the bolus with normal saline 20 ml per kg, give the adrenaline, give oxygen, give the steroids, and then only shift the child. Then, so for making it easy for us, this is a definition of anaphylaxis. If the onset is from few minutes to 6 hours, and if there are more than 1 signs and symptoms in any 2 systems, that is in respiratory, cardiovascular, dermatological, if more than 2 systems are involved, and even if 1 sign is there, like for example, swelling of tongue, and there is decreased level of consciousness, then you consider anaphylaxis and move on. And then coming to the anaphylaxis kit, this is a must have, even if it is a very small clinic that you're having. It is very simple. Just have a box with some 1 cc or tuberculin syringes, plenty of adrenaline vials, and then some cotton. And then you can, in addition, you can have fluid, hydrocortisone, CPM, and nebulizers. And this is a very simple chart. So if you have 0 to 1 year, give 0.05 ml of adrenaline. If it's 1 to 6 years, give 0.1, 6 to 12 years, 0.2, 12 to 18 years, 0.3, in adults, 0.5. So having this 1 cc syringe becomes very important, because in that situation, you may not be able to dilute it and use it in a bigger syringe. So to summarize, anaphylaxis is quite dramatic and quite common. So all of us should be ready in our clinics to face this kind of scenarios. Over to Janini, ma'am.
Yeah, I think you've made it very clear. I think these sort of charts should be stuck on the walls of the clinic wherever they are sitting and practicing. And EpiPen also, parents should be advised to get hold of EpiPen, because if it is a child who's getting a bad food allergy, then I think EpiPen is now available in India. So you should ask them to have that handy with them wherever they go, because anaphylaxis can kill a child if it causes a laryngeal edema. Otherwise, I think you covered everything. Yeah.
Yes, ma'am. Thank you. Next slide. So moving to the next child, he's a 7-year-old male. He's a known asthmatic. He's defaulted on MDIs and he keeps coming. So, and again, he started having cough and difficulty in breathing. Mother started with oral cocktail of all the cough syrup that she had. And then, of course, she gave nebulization with a nebulizer machine at home, which most of the parents do. They come and say that, we have the machine, we'll give the drug at home, and they have the stock of this dual and Budecort at home. So during, and this child came, of course, there was no relief, and this child was waiting the OPD, and then he suddenly had a very bad bout of cough, and then he vomited, post-octave vomiting, and then he started having difficulty in breathing, and then your receptionist rushed this child to your chamber. Supraja ma'am, what would you do in this scenario?
Yeah, I think the scenario is quite clear. This is a child who is a difficult to control asthma, defaulted on treatment, so has a huge risk for having a bad exacerbation. With all the clinical soft toys, the child possibly has had a bad exacerbation. So the first thing I would do is to check the vitals, and I would suspect an acute exacerbation. So when we check the vitals, what is very important is to actually remove the shirt, see the respiratory rate and the pattern of breathing, see how the chest and tummy are moving, check the saturation and as well as the heart rate, because we need to know what it is at baseline. And if there is severe respiratory distress, we need to act very fast, because this is the management of an acute severe attack with bronchospasm. So most likely the saturation would be less than 95%, and we need to initiate oxygen-driven nebulization with levosalbutamol and ipravent. We would do the back-to-back nebulization as well as alert the reception staff to get help, as this child needs to be transported to a center for admission. I would like to use a portable cylinder with oxygen and attach it to the nebulization kit directly, the flow meter, and keep the flow rate at least 8 to 10 liters per minute, so that I get a good fume for the nebulization. And at least 3 back-to-back nebulization would be given. Now, I also understand that giving a steroid is very important. If the child is already vomiting, etc., it's unlikely that oral prednisolone will work. I would like to choose IM dexamethasone, a big 0.6 mg per kg dose, which is given stat. And I would continue the oxygen, especially since the baseline saturation was low, and then consider shifting the child by ambulance. And if there is time and the clinic permits me, get an IV line ready and probably continue maintenance fluids or hydrocortisone with continuing documentation of the vitals. Now, although the ideal scenario is to check the saturation and the vitals, start the high flow oxygen, as well as the salbutamol or levosalbutamol nebulization with oxygen driven, and keep reassessment, the common challenges we face are maybe there is no pulse oximeter itself which is available, respiratory rate may not have been checked, and the oxygen cannot be used for our nebulization, and we use a nebulizer machine, which is really not acceptable, or we send child home after temporary improvement. So all these things are probably not the ideal scenario, and we should refrain from doing these things. Now, I would like to stress upon looking at our oxygen cylinder, see how the flow meter connects. Many times in clinics, I've noticed there is an oxygen cylinder, but the flow meter is not compatible. Next, the oxygen tubing is not being able to be attached to the flow meter. It's important that when we use nebulization, we don't use humidification, and we connect the flow meter directly to the nebulizer chamber, so it gives a good amount of flow rate and generates the mist. So we all know about assessment of severity and classification as mild or moderate, as well as the severe. What is important is never to miss the life-threatening asthma, especially when they have poor respiratory effort. They're hardly breathing, but they look drowsy, suggesting the carbon dioxide is way too high. They look exhausted. This is a time where we need to call our ambulance. We need to keep the bag and mask ready, and we need to directly speak to the PICU person. Maybe they would even come to retrieve. Next, in an acute severe asthma, we certainly have to start high flow oxygen along with the oxygen-driven nebulization and a parenteral steroid immediately. However, in the mild cases where there is breathlessness, interrupted speech, saturation is borderlining about 92 to 95%, and if at all we are good enough to do the PEF, we would notice that it is above 50%, then in that case, it is fine to start the treatment and reassess after that. So what are we actually starting with? We would start, although the guidelines say salbutamol, most of us use levosalbutamol, so we need to know the conversion. 2.5 mg of salbutamol is about 1.25 mg of levosalbutamol, and adding NS to it and giving the nebulization quickly with a high flow rate of oxygen is important. And along with that, to also include ipratropium. Now, we definitely can use MDIs as well, up to 10 puffs along with a spacer with a face mask, for sure. However, that is only when the saturation is well maintained and when the child's efforts are good. We need to check for the response. If the response is poor, we need to escalate and call for help. Okay, so we all know about the ipratropium nebulization. Generally, we use it as a combination with levosalbutamol, but we need to remember the doses in these fixed dose combinations can go wrong. So that has to be kept in mind, because a child who's above 20 kgs needs 500 micrograms, whereas less than 20 kgs need only 250 microgram per dose. Systemic glucocorticoids are very important. Dexamethasone given IM between 0.3 to 0.6 mg per kg, or prednisolone 1 to 2 mg per kg. Now, methylprednisolone is something I would use only in a hospital ICU setting, because it is given IV and it should be given slowly. Now, what are the common pitfalls? The first thing is just checking the saturation, respiratory rate can become a challenge. Using a multi-channel basic monitor is far more effective than just using the probe, because it may not pick up, especially as Swati already mentioned, in times of shock, etc. Secondly, it's very important that we always do it with an oxygen-driven nebulization. If there is no necessity for oxygen, then you'd rather use the inhalers. Thirdly, the availability of both continuous oxygen as well as oxygen-driven nebulization is very important with compatible equipment. And using the correct dose of levosalbutamol is important. Access to the parenteral steroids, and talking to the referral center, as well as the making an ambulance request. Janani ma'am, over to you for a summary.
Madam, please unmute.
Yeah, I've unmuted, yeah. So the only thing is, there's a lot of myth with use of MDIs. They like to use home nebulizers, but they don't like to use MDIs. So the practice of using home nebulizers should be just stopped. And we all know that without oxygen, when you give salbutamol, the VQ mismatch can lead to a paradoxical hypoxia and worsening of the child's respiratory status at home. So you have to put that fear into the patient's mind and remove the myths of using MDIs. And MDIs, you can use it in mild and moderate asthma, where the child is not hypoxic and the tidal volume is good. You can just ask them to wait in the OP, give about 6 puffs every 20 minutes, and give a dose of oral steroids in between, and then reassess and give them a nice plan and ask them to come back and report a week later. Acute exacerbation, of course, I think she's covered it really well. It's not enough if you treat the acute exacerbation. You should also teach them the proper use of MDI. We've done a study and found that the spacer, how they use is very, technique checking is very important. How they maintain the spacer is important. It's not enough if you write, but you'll have to explain the technique, tell them how to maintain it, how to wash it and reuse it, and also how they check the dose and attach the canister to the spacer. All that is equally important, spacer. All that is equally important. And I think she's covered the acute exacerbation, and also avoidance of triggers has to be stressed to the parents. You know that there are known triggers, they have to avoid that. Dust control measures and pets, avoidance of pets and all that. So it's complete, your plan, your treatment becomes complete only when you do the entire counseling, including avoidance of triggers and frequent follow-up and looking at the FEV1 and spirometry and others. That's it. Yeah.
Thank you so much, ma'am. Moving on to our next case. This is our old patient for the last 8 years. The mother recently delivered a preterm baby, 28-weeker, 980 grams with 2 months hospital stay, multiple NICU problems, finally discharged at a weight of 1.9 kg. 4 days ago. Now the receptionist got a call from the anxious mother saying the baby is making a moaning sound, so needs to meet the doctor urgently. The hospital where the baby delivered is about 10 kilometers away. Hence, the baby was rushed to your clinic, which is easily accessible. Now the baby noted to be grunting and irregular breathing, looking blue and mottled. So Swati, what next?
Yeah, and this is a quite common scenario. In this case, this is a preemie who is growing at home. Probably there could be an aspiration. Not only this, small infants, very common aspiration is very common. Hypothermia, they feeding something else. Especially in the rural setup, I feel this is very common thing. So here the child is definitely looking blue, irregular breathing. Child is definitely in respiratory failure. Only thing which can save this child is a proper bag and mask ventilation with an oxygen, and that is the only thing. Otherwise, the child might, if even the child comes with a heart rate, child will definitely easily go to bradycardia in the next few minutes if the ventilation is not given. So we have to start bag and mask ventilation, try to establish an IV access and get a GRBS by then. If there is hypoglycemia, we have to give 5 ml per kg of 10% dextrose. And if the child's peripheral pulses are not felt, maybe start with a saline bolus. Here again, you are doing bag and mask ventilation one side IV access. So you and your staff is busy. Definitely this child requires intubation and mechanical ventilation and further management. You have to ask for help. Probably a team next to your the closest hospital, if they can come and retrieve this child safely and go, then it's well and good. Otherwise, for medical legal purposes, if you have resuscitated this child and you're able to manage to secure an airway, better to transport this child safely and drop the child to the nearest healthcare system. So what the message I want to give is, here the bag and mask ventilation plus cardiac compressions if the child is having bradycardia is a life-saving skill. And these infants have a very survival instinct, very high survival instinct. A simple CPR can save them in this scenario. The challenges we face is a small size mask. Your bag and mask, it comes in 3 sizes: 0, 1, 2, 3. So usually 1, 2 we easily get. But in the premature, we need a smaller size. So if your bag and mask size is not appropriate, then your bag and mask ventilation may be inefficient. You may not be able to get good chest rise and breaths. And having a suction apparatus becomes very important. And if you are taking care of the airway, somebody has to give a cardiac compression. So all the staff must be, trained to give a BLS, a good cardiac compressions in this child. Any more comments, Janvi ma'am?
I think you've made it very clear. I think the key in this child is, as you said, good bag valve mask ventilation. So I think everyone has to be trained, including the receptionist or the helper, or anyone can pitch in and help, because you need two people have to be there. One has to give the bag valve mask and one has to give the 2-finger technique, or you can do the 2-thumb technique or whatever, because it's a preemie. It's almost like a neonate. So it will be like you'll be following the NRP guidelines. So train them in both. And I think that's life-saving. And as you said, the mask sizes have to be checked, and oxygen source and your emergency drugs and all that has to be there. That's most important.
Yes. Moving ahead, another very common scenario where the parents are horrified. This child was bit by a pet dog near the face and the eye. And parents will tell, this is a pet dog. The dog is, our pet. So that is one common thing. And Here, what has happened, there is a small subconjunctival hemorrhage as well, because the bite was near the eye. And the neighborhood friends have reassured because it's a pet dog and the dog was vaccinated. However, the wound was burning after application of Dettol and child was brought to the clinic. Very common scenario. Supraja ma'am, what would you do in this?
Okay, so this is definitely a common scenario. And the first thing is whether it's a pet dog, vaccinated dog, whatever dog it is, it's a dog bite, it is an exposure, there is a risk of rabies. So I would first initiate basic first aid, which is thoroughly wash the wound with running tap water for about 15 minutes and ensure that the local decontamination is done. And if we put an antiseptic, that is also fine. It acts as a virucidal immediately. Irrigating the eye with saline is also probably important. Then I would quickly educate the parents that this is a serious category 3 bite and we definitely need both the complete course of rabies vaccine as well as the monoclonal antibody. I would take a quick history whether the child has ever been bitten before or ever taken a vaccine in the last 3 months. If that is not there, then the child definitely needs the vaccination. Now, the important point is when I'm using the monoclonal antibody, which is effective and much cheaper, I would ensure that I would as much use it along the local area. So I'm no longer going to give an IM injection like what we did before. So since it is closer to the eye, we even had children where it was only internal, inside the eye rather than external. So I didn't know how to inject it around the eye. I would definitely do a local infiltration, flush the area and including the conjunctival area completely and the lids with the correct dose of the monoclonal antibody, and as much possible also infiltrate subcutaneously around that region. Apart from that, I would give the ARV and give the regimen to the parent on how it should be taken and the dose should be completed. And lastly, I would tell them about the precautions that children need to be mindful and this is a serious condition.
Yeah, I think, yeah, this is a category 3 bite. I think we are still seeing deaths due to rabies, which is very, very unfortunate. I think we should take it very seriously and we should try to give whatever monoclonal or whatever, try to give as much as possible infiltration around the wound, and the remaining has to be given as intramuscular. So that is very important. And also talk to them about pre-exposure prophylaxis. Those who are having pets at home, I think definitely pre-exposure prophylaxis is important because this is a pet dog, definitely vaccinated, but still there is a risk. And when the bite is closer to the brain, that is in the face, it's more risky. So I think we should educate the parents and talk to them about completing the course of the vaccination 0714 03714 to 28. 14,
Yes,
yeah, 14 or 14 and 28, either of that. So I think we should mark the dates and give them and make sure that they get the vaccines completely. Yeah.
Thank you so much, ma'am. Moving on to almost our last case. This was an 8-year-old boy who was cycling in the apartment complex and suddenly was hit by a Swiggy scooter. The child fell and the bicycle handle hit his abdomen. There was no external injury except minor abrasions over the right arm and shoulder. There was no loss of consciousness and the child denies any head injury. He walked home and told his parents. 2 hours later, the child was complaining of dizziness and refusal to eat his dinner. He was nauseous, so the parents brought the child. During waiting in the busy OPD, the child became drowsy and had one episode of vomiting. The receptionist rushes the child in. So, Swati, what you're suspecting and what would you do?
Yes. Here, ma'am, go back to the question. So here, what we can see that the child does not have much of external injury, but this is a cycling injury. Bicycle injury is the one which can stay silent. We've had children coming after 24 hours, coming with a distended abdomen. So you have to look at the mechanism of injury rather than look at the external injury and think nothing much might have happened. So even if there is no head injury, abdominal injury is quite serious and the internal bleeds can go silent for a few hours. So in this child, the child is becoming drowsy. Probably in the absence of head injury, if the child has become drowsy, the child might be having a hemodynamic instability because of blood loss. So going ahead, I think this child is having cold peripheries as expected. Child is having tachycardia, saturation is low, BP is low. So this child definitely has an internal bleed causing hemodynamic instability. So this is an emergency. Again, we have to do ABCD and also, call for help, ask the team to come and retrieve, and then go ahead with your further resuscitation. So this child is in hypotensive shock. Becomes very important to replenish the losses. Definitely, you will not be able to arrange blood. So at least start with normal saline bolus, and then maybe you can start an inotrope till the blood is arranged. And ma'am, next slide. So here again, if the team is coming well and good, otherwise you have to go with the child and transfer the child in an ambulance, and then high flow oxygen has to be started. And then wherever you're sending the child, tell the history, ask them to arrange blood and keep ready. Otherwise, even if you're transferring, they might take their own time to arrange the blood. Blood becomes very important over here. And the child has fallen down from the cycle. So we never know about the spinal cord stability. So here again, put the child on a spine board. If you don't have the cervical collar, you can use 2 saline bottle. You can wrap it up with bed sheets and make a stabilize the spinal cord. As I already told, establish IV access saline, and maybe IV tranexamic acid might help. So again, to reiterate that bicycle handle injuries, or even if the child is get hit, the mechanism of injury becomes very important. If there is speeding car involved in the injury, even if there are no external injuries, guess that there is internal bleeding going on and do the needful. Ma'am, over to you.
Yeah, of course, the management you've dealt very clearly. It's a blunt injury abdomen and you've managed it really well. But that's the other part is the medico-legal aspect.
Yes.
You'll have to, this is a medico-legal case because it's a road traffic accident. So you'll have to properly document and inform, file an FIR, inform the police. And that part is very, very important. And I think, of course, the Swiggy person has to tackle the entire thing. He has to be held responsible. And otherwise, management of the blunt injury abdomen was dealt with very clearly. It is important to give Paxil transfusion after the fluid bolus in any child with hemorrhagic shock. That's very important.
Thank you, ma'am. So we also have a whole array of non-life-threatening emergencies, be it a pulled elbow, or be it a paraphimosis, or a sprain and paronychia, the penis getting caught with a zip, and nail bed injuries. Now, it's interesting how we would deal with this in today's medico-legal era in a place like, for example, Bangalore, where there are more hospitals than there are Darshini hotels also. So I guess the approach to these non-life-threatening emergencies would be, first of all, to assess what is the services available. If I am practicing at a periphery or a semi-urban area where access to a specialist like a pediatric surgeon, etc., is limited, then I would not convert a non-life-threatening to become a life-threatening or a limb-threatening injury. I would probably upskill my OPD practice to learn to overcome most of these problems. But when I'm practicing in a center where experts are available, I would rather refer this child to an expert than to sort it out myself. So generally, these things, like, for example, a paraphimosis, etc., is best done by the expert like a pediatric surgeon. However, if they are not available, they are in OT, or for whatever reason, we can counsel and talk to the parents and then make an attempt. But proper training is required, because if something goes wrong, the onus is on us. There is a good IAP poem module, which I think was released 2 years ago, which is extensive and deals with most of the emergencies, the non-life-threatening emergencies in the OPD. So let's come to poisoning. This is something which can happen anywhere, household as well as in the OPD. So when such a poisoning happens, what should we do? It could be easily available poisons like camphor or cleaning agents, or it is so horrible to see that paraquat is actually the most deadly kind of poison, is so easily available on Amazon. And we know that there is hardly any treatment for it, and almost always causes death. Likewise, paint thinner can cause a severe respiratory problems. So let me just ask Swati what she would do in a case of poisoning and they come apparently stable to the outpatients.
Yes. So here we have two kinds of scenario where a small child, toddler, unintentionally, accidentally took a poison. Most commonly, it will be like, the all-out liquid or, it could be some serious stuff like rat poisoning. And another group of intentional, in adolescent groups, intentional, that is usually paraquat and usually these, toilet cleaners, which can be really, really bad. So one thing is best is to find out, notify first, because especially if you're not sure about what the child has taken, usually the parents bring the thing. So if you're very clear, then you can go ahead with gastric lavage and so on. But if you're not clear, definitely you have to consult the National Poison Center. These are the numbers. Then if you're very clear that this child has taken a non-corrosive, non-volatile and potentially life-threatening drug, then you had go ahead with the gastric lavage. But again, it should be within 1 hour and it should be in a conscious child. Otherwise, you may do heroics in your clinic and the child might aspirate and you create more harm. And then because again, it's a minimal benefit. If your nearest hospital is within 10 minutes of vicinity, and better to ship the child as soon as possible than do the gastric lavage and waste time. And activated charcoal is indicated, especially in some phytotoxin and drugs, and preventing absorption from the gut. So again, the important point is consult the National Poison Center. Only if you're sure of the poison, go ahead with the gastric lavage and activated charcoal. And better to inform the, and again, medico-legally important. So you have to put a medico-legal case and notify the police about this.
Chanima?
Yeah, I think you've seen all freaky poisonings. All these children can have anything, household things. I think you should have again a list of what are the poisons that does not cause any simple thing like crayon, lipsticks, color pencils. Then they lick all these chalk peas and everything. So those are all non-toxic. So the non-toxic and toxic, you'll have to separate and list, and then also have common antidotes for poisoning has to be there. The common thing is they consume the tablets which the adults take, the oral anti-diabetic drugs, anticonvulsants, all that they take by mistake or just out of curiosity, they just take it. And I think you should have antidotes for all that. And I think naphthalene balls, camphor, all these are common things that we come across. And I think the poison center number is there handy with us. The CMC Vellore, it's a 24/7 center where they give you immediately, they give you the antidote with the dosage. So that's really helpful. It's good to have a list and good to have common antidotes. Yeah.
Thank you, ma'am. I just one word about the CMC center. In the last 10 years of our practice at my hospital, it's a compulsory that we contact them, even if it's a silly household poison.
When we do that, yeah.
Yes, ma'am. And
Same
they
thing.
always answer. They are so prim and perfect, and they give us proper advice. No need to admit, etc. So really hats off to them.
Very, very useful. Yeah. I think the practitioners can take a screenshot and have this number with them. It's very handy.
That's right, ma'am. That's the reason I put it up. Thank you so much. Now, before we wrap up, thank you to all of the practitioners who have answered our Prep Up questionnaire. We had 60 people who have answered. I have prepared these slides where 55 of them have been included. And it is very heartening to note that more than 60% are actually senior pediatricians who have filled this up. And we also had most of them practicing only pediatrics in their clinic. So it was not like a multi-specialty type of OPD. And it was interesting for me to note that almost like 2/3 are the ones which are linked to a pharmacy. So that way, access to medication should not be a problem. Probably if we stock the equipment very well, the access to medication should be quite easily, which is good. Now, regarding where the clinic is noted, mostly the practitioners from Karnataka have answered. From the taluk and district levels were about 38%, and about 25% is from Bengaluru and other cities, and here and there from all the other places of Karnataka. Now, this is very interesting to note how frequent are the emergencies in the last 1 year. It is important for us to know that almost 40% of them had seen an emergency once a week or more. That means Prep Up becomes very, very important. And about 30% of them are at least seeing it once a month, which is 12 emergencies in a year, which is important. The rest of them is quite less. Now, coming on to the common emergencies that we see, although there is a mix and there is a combination, like Swati said before, respiratory and wheezing emergencies are the most common, followed by seizures and minor trauma, as well as shock and dehydration. So keeping these statistics in mind, we can also keep our equipment as categorized as airway, breathing, and circulation equipment. Now, looking at how close our practice is to the emergency of any hospital, most often, almost 3/4 of them have answered that it is within 10 minutes. That's because of the boom of hospitals that we have, mostly in city and now in district areas as well. But about 20% of them need to have it between 10 to 30 minutes. So we need to do some degree of stabilization before referring. And a minor percentage of them is above half an hour, where serious stabilization is required before referring. I will request Swati to say a few slides.
Yeah, so about the staff, I think this is the most common problem. So we usually have OPD and one receptionist, so that we can see that only here. So most of the 29% of them have only 3.
Yeah, I think you continue.
Yes. So what we see here is it is quite equally distributed. The minor of them is only the pediatrician. Almost 1/4 of them, 25% in each category. That is, they either have 2 people or 3 people. That means somebody is there with us whom we can train and who can partner with us to help in these emergencies. Now, coming on to before an emergency occurs, are we actually preparing our patients in any way, giving them a printed material, etc.? 40% have answered yes, partially they are preparing their patients, and about 30% have said no, they don't, so that there is scope to improve. And it's very heartening to know at least 1/4 of the practitioners have said they have a structured written protocol as if a patient has an emergency where they should go. I've in fact seen it printed on many prescriptions where senior pediatricians have said, if the child becomes sick, go to X hospital.
They usually have it at the bottom of their prescription.
That's right, ma'am. That's right. So that is a very effective way. Then the question about, do all staff working in your office know how to triage and call for help? About 1/4 of them, they have said no, they don't know. Another 1/4 of them say some of them know, but it's good to know that almost 50% actually know how to triage and call for help. Now, this is very important. Is there a written protocol to follow during an emergency? Majority have said no. So here we have scope to improvement to keep a very simple written protocol, a simple SOP onto how to call the ambulance, simple SOP for febrile seizures, and the common ones we discussed may be useful. Now, again, looking at which ambulance service we will call for, the private or government, it is known that the private ambulances come within 15 minutes in 67% of the cases, and about 30% of the cases, the government hospital also, the 108 ambulances come within 15 minutes. So we do get access to emergency service if we call them early. Now, this is a very important slide. Now, it is very important that all of us as pediatricians dealing with children know how to do basic life support, not just for the child, but also for an adult who collapses in our clinic. It will be very hard on us if we don't know how to do BLS. And unfortunately, about 45% are not formally trained in basic life support. And it is something we can definitely, through IAP, get trained in a simple method, at least for BLS, choking, foreign body, as well as CPR. Now, is there any formal training done for the staff? More than 70% have said there is no formal training done for the staff or for themselves. So here again, through IAP, we can bring up the PrEP module in various clinics. Now, coming on to equipment, the one thing which strikes here is there is no equipment which is 100% present in all the clinics, which is not very good. At least a bag and mask. Imagine if we had that preterm baby coming into our clinic and we can't even resuscitate. We'll feel so helpless. This parent we know for 10 years. So it is important that we have a basic bag and mask kept in our clinic, a basic resuscitation. We don't need intubation. We just need bag and mask. We need oxygen. We need some method to check the glucose, and we need IV access kept there. The rest of them, or even a suction, can make a huge difference. So the airway, breathing, and circulation equipment is important. All the other things like cervical collar, spine board, intraosseous, LNA, etc., they are luxury. But at least the basic things have to be kept. A multi-channel monitor with the BP apparatus is important in today's times. Now, regarding the medication, again, it is very sad to know that there is no medication which is 100% present. Like adrenaline has to be kept, whether it's anaphylaxis, whether it's arrest, we need adrenaline present. And apart from that, things like midazolam nasal spray, midazolam vial, and anti-seizure medication, paracetamol, etc., glucose and saline are very important, apart from oxygen to be kept. Now, do you have any ready-to-read management guidelines? About 50% have said no, and the rest are in process of getting it. Okay, what are the practical challenges? Now, this is very, very important slide. Almost 50% have answered it is cost. It's not just a one-time investment, because the adrenaline will expire or the oxygen has to be refilled. So it is an ongoing practice change. In fact, it is a culture change, I would say. So it's very important that we bring in that rigor into our clinics. And it's not just in India, even in the West, with such good equipment, etc., none of the clinics are very good. They'd rather rely on EMS, but their EMS response is excellent, and they would come and the paramedics would do most of the resuscitation. Unfortunately, our emergency medical service, it's good in terms of transport, but in terms of stabilization, still we have a long way to go. Until it reaches the tertiary center, we will not be able to stabilize, and the onus is on us. Medical legal onus is on us until we shift to another doctor who is capable of treating. So do you perform mock codes? A whopping 75% have said no, no idea about it, and have not performed it. So there is scope to improve here. And do you think it would be useful to have a training session? It's very heartening to see more than 80% have said yes, they would want a training session or a mock simulation. It would help to get better trained. And again, a guideline from IAP is requested. And at least 60% have encountered a life-threatening emergency. So it's very important that we have the life-saving equipment with us. Thank you so much for your attention.
Thank you. I think Supraja that was very helpful. The survey, we know where to, which area has to be tackled and which area has to be addressed. I think it was a wonderful session. I think I should thank the excellent covering of cases by Supraja and Swati in a very nice manner, covering all aspects. Thank you.
Thank you. Thank you, Dr. Janni, for summarizing, and thank you for the wonderful presentation by Supraja and Swati. I think, Dr. Janni, you have answered most of the questions.
Yeah, answered most of it. Yeah.
On which are in the chat group.
Yeah, I've answered. Yeah.
If there are any questions from any of the audience.
Unmute yourself, you can answer. I ask.
Okay, there's a
Any
question
questions?
here. Where do we get the poem module?
I think there was a book release, no, ma'am. I was a part of this module.
Okay.
I think there is a PDF released 2 years back. I think it was in 2024. I'll just try to get hold of that.
Yeah, if you have the PDF,
Yeah.
probably you can share it with us.
Yeah.
And it's mainly for non-life-threatening emergencies.
Yeah, it's all the small things.
It's all non-life threatening. Yeah.
Yeah.
Okay, I think, yeah, there's a request for a PDF of this session. Dr. Krishnan has asked for a PDF of this session.
You can share the PowerPoint.
We will share.
Can we share the PowerPoint, Dr. Supraja?
Yeah.
Yes, I will share the PowerPoint.
Okay.
We have to make it a PDF.
Yes,
Yeah.
yes.
PDF
You
and
could
share.
probably send it to Dr. Ravi Shankar or Dr. Kushal and it could be shared.
Yes.
So
Okay.
I think that's with that we are at the end of the questions. So thank you so much, and it's back to you, Kushal, and thank you for the opportunity given. Thank you.
Thank you very much. And it was a wonderful presentation by Dr. Supraja and Dr. Swati, and well commented by Dr. Janani. And Dr. Janani was told in the National Pedicon by our co-panelist, Dr. Jayavardhan from Coimbatore, about how she has done the work to the PICU enhancement in Tamil Nadu, all over in Tamil Nadu, in Taluka and district branches also she has developed the PICUs. Very thank you, madam, for this. And being a judge for this, it's wonderful, and your comments were well taken, and we appreciate that. And I would like Dr. Ravi Shankara to do the closing comments, our president.
Yeah, thank you, Supraja and Swati. I mean, really, you have done a wonderful job and taken lot of efforts to get the cases, which are very practical, and office practitioner will face that one and how to manage them. Thank you. Really, you told it in a very nice way. And of course, Janani ma'am has already given her expert opinion on most of these things. And really a wonderful session. And the most surprising thing was the survey. So that is a very good survey, and we know how what exactly the problem is there in the office practice. Why many people still not keeping the emergency medicines, everything. It is a wonderful survey. Probably we can publish that survey somewhere, and so people should come to know about what exactly is happening.
Correct.
Somewhere in our
Very
Pedicon,
useful. Yeah.
very useful survey. Probably we'll see how we can publish that one. It is a very good survey. Thank you once
We should
again, all of you.
request for
Thank you,
100
Janani.
people, sir.
You did
We
it
need
on
more
100
entries.
people, is it? Yeah.
Yeah.
Yeah, actually, I
Yeah.
did, after the PALS was introduced, I did a survey like this, impact of PALS on their practice to people who are practicing, no? That was published actually. So I think that is what I'm saying is about 25 years back, almost 95, 96. So I think you can, 30 years back, you can get this published. This is very good.
Thank you.
And also
Thank you.
try to address all those lacunae, not only publishing, but also address those lacunae.
Yes.
So thank you. We'll meet after
Yeah, I think
15
I
days
should
later.
thank
Yeah.
Ravi Shankara sir, Kushal and Sumita
Thank
for
you,
this wonderful
Thank you so much.
opportunity.
Thank you.
Yeah, and
Thank
I
you.
enjoyed Supraja and Swati, the two young, energetic, enthusiastic intensivists who did really like a coordinated session. It was like a Jugalbandi. Very nice.
mentor and mentee.
Thank you so much. Before we close, just an announcement. The next session would be on February 11th, another interesting session on headache in children. So we
Great.
would be having some neurologists coming in and discussing cases. So thank you so much. And back to you, Dr. Kushal.
Thank you, madam. Thank you. Thank you. I
I
thank one
request
and all.
here the people to, give, send a message about this K Samanvay to others. So let lot of people join and interact with us. So that is my request to hear people here.
Yes,
So,
sure.
thank you.
I think today
Yeah.
was almost 80 participants were there. So amazing initiative, sir. Superb. Sumita
Thank
ma'am,
you. Thank you.
congrats.
Amazing.
Yeah.
Thank you so much, Sumita ma'am and Ravi Shankar sir.
Yes.
Kushal, everyone. Thank you very much. And especially Janani ma'am.
Yeah,
I
we
didn't
are
do
very
anything.
lucky to get the launching session.
Thanks.
Thanks, Janani
Thank
ma'am.
you.
Thanks,
Yeah,
ma'am.
yeah. Bye,
Thank
bye,
you.
bye.
Thank you.
Bye, bye.
Bye.
Good night.
Bye.
Good night.
Bye.
Good
Yeah.
night, madam. Good night.
Have a
Good
wonderful
night.
rest of the
Good night.
weekend.
Good
Bye.
night. Good
Yes.
night. Bye.
Thank you.
Bye, Sumita.
Bye. Bye.